Good to see you all. So my name is Scott Stuewe. I'm President and CEO of DirectTrust. Really eager to kind of share with you kind of what the latest is in the direct secure messaging ecosystem. It is not your grandmother's direct or your mother's direct or your brother's direct. It's a new animal today. So DirectTrust, if you don't know who we are, we're a not-for-profit trade association, a C6, made up of organizations that are dedicated to this notion that we've got to establish trust in a connected world. So connected world meaning we live in an internet-connected environment. We know what that's like. So we have both we have a bunch of different kind of core elements that are pieces of what we do. We are a membership organization, and that's for the organizations that want to support this mission, including those who operate our network, which we'll talk about on the next slide. We also do standards development work. We'll talk a little bit about some new stuff we're doing at the end here. But standards, we're the custodian of the direct secure messaging network, as well as the direct standard, which is the standard that supports it. We also do accreditation of our accredited HISPs that operate the network, but also a bunch of other kinds of organizations that, frankly, are the ones that are looking for a compliance verification or assurance so that their third parties can be certain that they're taking care of their cyber health. So that's our accreditation business. We also do a series of trust services, including high trust assessment, but most of our trust framework work is in the relationship between connected parties and the use of digital certificates to ensure that those connections are secure and identity assured. So that's kind of the high level set of stuff. In the trust services space, folks may not know that we currently also do the certificates in the TEFCA ecosystem and look to do that also in the TEFCA FHIR ecosystem. So that's a piece of what it is we do on the trust services side. The network I mentioned is really a big piece of what it is we're known for. It's not all we do, as I just said, but it's the focus of this conversation is direct secure messaging and the direct secure messaging network. So we, at this point, are seeing, at this rate, seeing 272 million transactions in a quarter. We're looking at basically 1 billion transactions a year at that clip, which is pretty remarkable. This has been a growth pattern pretty much from the beginning of our existence in about 2012, when Direct was first a part of Meaningful Use Stage 2 and got deployed to basically every electronic health record company or electronic health record in the country. So we're connected to 300,000 organizations or more, 314,000, which is obviously organizations that are not all healthcare providers. That's more than the providers and the hospitals together, right? So that's also a bunch of CBOs and some HIEs and payers and lots of other kinds of organizations are in that mix of organizations we currently connect. And we've made about 4.7 billion transactions happen over the course of our existence. This is a very robust network, but it's not well known, frankly. So direct is can be a little bit behind the scenes for people. They don't know that it's theirs sometimes. They have it, but they don't know they have it. And this is a problem for making good sense of it. The other thing about direct, which is both maybe a good thing and a bad thing, direct is what they call payload agnostic, right? So you can put anything you want in a direct message. That's good on the one hand. The standard is payload agnostic, but the connected parties are not. So the connected parties meaning organizations like when you're connecting to an EHR company, they may have very specific expectations about what the payload can be. And so in the absence of really clear expectations about what a payload is, a lot of data was not making it to where it needed to go. And so what happened when the CMS ADT condition of participation came out? Now, I'm sure everybody here knows that this is an obligation now for hospitals to send notifications about their patients when they admit or discharge or transfer. Those event notifications are an obligation for senders. There's no obligation for the receiver necessarily, and there was no stipulation for a standard expectation. It was just do this, but there was no indication about how you were going to do it. So at that point in time, working at DirectTrust with our convened parties of our members and actually non-members who are EHR companies, they came to us in large numbers and said, help us standardize the payload for notifications, because it's going to be a mess if everyone just sends different things and that all of the different standards they might choose to send stuff with. So direct secure messaging, for the first time in history, became differentiated in a way that it is very, very useful. So differentiated messaging on a network is really useful because senders, they can send to a receiver, and a receiver can know what they're going to do with this based on what it is. So if in fact you're talking about a transition of care, which is this is your father's direct, right? So transitions of care were the obligation under meaningful use, and referrals. Okay, so those things are still happening in our network, but increasingly a whole lot of other use cases are happening, and people can't tell what they are, like unless they are differentiated in some way in metadata. So the consensus body convened 40 organizations that got together to do this work. We really pretty quickly, 3 years, that's really fast for standards work. Okay, that's how long it takes to do standards work. This was 40 competitive companies coming together to say how this is going to work. It took a long time, but when it came together, it made a huge difference. So what we did, we built it on existing standards. We actually incorporated things like an HL7 v2 ADT, right, so that everybody already understood how to do, but we also constrained the ADT because HL7 is not completely restricted. Like you can send an ADT message. Your ADT might look so different from this other person's ADT, you don't even recognize them as the same kind of message. They're that different. So we constrained them. We said, okay, your ADT message needs to be a little bit more constrained. And we put metadata in the message, both inside the message and also in the header of the message, so that people could make decisions about what to do with the message based on what they were getting. They're looking for the LOINC codes in the metadata to decide, is this a transition of, is this a transfer or a discharge or an admit? And so this is what's really important to them, because the provider may want to do different things based on those answers. Like they may want to receive only notifications about admits and not about discharges, or the other way around. Or they might only want to receive discharges on patients with certain kinds of discharge dispositions. So like if I'm discharged to home, do I care if I'm instead discharged to long-term care? It's really important to me. So these are the kinds of things that we try to make possible with the standards work. So we applied these concepts then to try and figure out, well, how can we do this in other ways? This is actually sort of the same pattern that is represented by another cool thing that you might not have seen. This, actually, I would love to be able to show you with more time, because we just have 30 minutes here, so I'm not going to have an opportunity to show you but there is actually a video on our website of closed loop referrals. 360X closed loop referrals is more or less the same transactions pattern that the notification stuff represents. It has metadata, it is differentiated, and it is designed for communication of referrals with the ability to close the loop back to the sender with a referral ID. The thing about referrals is they're recursive. They go back and forth and back and forth. In fact, they may come to one original receiver, and then they may deny the referral and send it back, and then you need to go to another place with the referral request. And once it's accepted, then that patient finally shows up, and the consult then needs to come later. All of those transactions all have this one piece of metadata, makes it possible for you not to constantly be doing patient matching between these transactions. So it's a very slick standard, and it's a good way of thinking about how we can do direct in the future. So we are actually embarking on a standards piece of work right now that is, we've started to call, just as a skunk works, we're thinking of it as calling common conveyance. Like what for the next thing we're going to want to do in direct, what is it we can all just use as a cookbook to quickly build a standard that supports laboratory results inbound, for example, which is a perfectly valid approach for direct, but not unless the receiver can figure out what they've got in the payload. So this is so it's really a great opportunity. Now, the really interesting thing is, what can you do when you get an organization like Kanza So Laura McCrary is with us today talking about things that they did at Kanza that took this basic thing, this basic pattern of notifications, and advanced a really unique and special use case that has application to so many different interesting things we could do in healthcare. So, Laura, go ahead. I think you're gone.
Okay, can you hear me okay? All right, super. Well, hi, and thank you so much. This is fun for me to talk about with you because I actually love this project that we did. Partly I love it because it's practically low cost, no cost. It already uses existing technology that most of our organizations have, and it really makes a really important and critical difference in the safety of patients and in the safety of the staff at the different facilities. So as Scott said, we actually maintain 2 high trust and direct certified HISPs that we use as a part of our health information exchange and as a part of our QHIN. And so when we began thinking about how to address this problem that was brought to us by our state public health authority, one of the things we thought was, what is sort of ubiquitous that everybody has access to? So anyone who has an EHR system has to have direct messaging as a part of their EHR system. And that allows a message to be delivered to a clinician that has a direct email account, and then that clinician then can do a variety of things with it. And so we were thinking about how do we utilize this resource that we have when the state came to us and they said, we have a real problem in the state of Kansas, which is that our MDRO population of people with multi-drug resistant organisms is growing in Kansas. And part of the problem is that when patients are admitted into the hospital, the infectious disease specialists at the hospital are supposed to check the MDRO registry at the state. But as you might imagine, that doesn't always happen. The infectious disease specialist might not be there at 2 in the morning when the patient is admitted, or they might not have had a chance to look at the updated list from the state, or the state might not have gotten, the list available. So what the state said is we need to create a way to alert the infectious disease specialists when they've admitted a patient into their own hospital that has MDRO. So we thought about that for a while, and we were fortunate in that we had the key things that Scott was talking about are necessary to be able to make that project work, because they were already in place as a part of what we already do as a health information exchange. So first of all, we receive ADT feeds. Most of you are probably familiar with what an ADT feed is, admit, discharge, transfer feed. Every hospital in the state of Kansas sends us those feeds. They're required to do so. So we get that information. So we know usually within 30 seconds to a minute, we'll get an ADT that says a patient has been admitted into the hospital. And it'll tell us what the patient name is, and we'll have some basic demographic information on the patient. And that comes in real time to HIEs all day long, every day, all night long. They're coming in constantly 24/7. So the state also had a list of patients that was on the MDRO registry. It wasn't a lot of patients. I think it was about 470 patients in the state of Kansas on the MDRO registry. But if any one of those patients was admitted into the hospital, that patient would not only, would infect the other patients at the hospital, but they'd also infect the staff at the hospital. And the goal is to isolate those patients as quickly as possible. So we were trying to figure out what is the best and the quickest way to do this that would be, everyone would be able to have access to it. And direct messaging and kind of what Scott was talking about, we thought, well, my gosh, this tool is already in every EHR system that's out there. It's required to be there. As long as we can get the direct email address from the infectious disease specialist, we can get the ADT, match it up against the state's registry, and then we can send the alert back over to the hospital that admitted the patient and say, hey, 3 minutes ago you admitted a patient that has MDRO. You need to get that patient isolated, and you immediately need to get your staff, in secure, secure containment situation. So we thought, though, that kind of makes sense. Doesn't seem like it's very hard to do, not very expensive. And so we thought, well, do we really think the infectious disease specialist people at the hospital will want to do this? That was kind of like the next thing. we approached some of the biggest hospitals in Kansas, and they were like, hey, yeah, that sounds great. Let's get that set up right away. And the state, of course, was actually purchasing it for the hospital, so they didn't have to pay anything. It's the state's responsibility to make sure this gets taken care of. So the state was going to pay for it to be put in place for them. And so we've got about 8 of the biggest hospital systems set up now. Interestingly, when we do this, you can go ahead and move to the next slide. When we do this, where we found to be the biggest problem is that the infectious disease specialists at the hospitals have never been given a direct email account address. They don't have one. They don't have one. So when we start to talk to the infectious disease specialists, the very first thing they say to their IT department is, why don't I have a direct email account? Because I can't get these alerts if I don't have a direct email account. That's been the hardest thing to do. It's turned out it's been like 2 weeks in some situations just to get the infectious disease specialists a direct email account. But this is the workflow that you can see up here. It's kind of hard to see it. But basically, it's so simple that any of you could probably do this with your health information exchange or with your direct messaging providers. So basically what happens is, everybody has these direct email addresses once you actually get them for the infectious disease specialist. We actually have the ADTs coming in as a health information exchange. The public health department has the list of the patients with MDRO. And then you just simply match them up and send the alerts. Now, one thing we've also found is that some of the hospitals aren't getting their ADTs to us as quickly as we had thought they would. And so it's been a good opportunity to really focus on, how do we get you to improve more quickly getting your ADTs to the HIE? Because in some cases, our goal is to always have the alert to the provider, the infectious disease prevention provider, in under 5 minutes of the patient being admitted. But if we don't get the ADT till 7 minutes after the patient's been admitted, then we're going to be behind. So our goal now is to work with all of our healthcare systems to make sure the alerts get to us in under 3 minutes. The ADT alerts get to us in under 3 minutes. We get it back out to the infectious disease provider in under 5. And so a very simple and easy concept with direct messaging. Let's go to the next slide. This is what the providers actually receive. This is the message that comes in to the infectious disease provider, which basically tells them about the patient that they've already admitted at their hospital and tells them the reason that they're getting the alert is because the patient's on the state's MDRO registry. And it seems to be working really, really well for the infectious disease folks. We've asked them for input on how would you like to change this? Is there additional information you would like to see in these messages? But this seems to be sufficient, and they seem to be able to immediately get the patient secured and get their staff secured with what I consider to be a low or no cost health tech solution that's already in place in almost all of your states and then your networks across the country. So we're excited about people taking this idea and going and implementing it yourself. You don't need us or any special technology to do this. You guys already have all this technology. All I have to do is share with you the idea, and you can take it home and do it yourself. And so I'm excited also to think about what else can we do, right? So now that we've figured this out on MDRO, what else can we do as we think about this? So the patient has been discharged, right? From the hospital. Well, we know the patient's been discharged from the hospital within that same less than 5 minute time period. Can we alert a care coordinator that the patient's been discharged and let that care coordinator know that the patient's going home today? How about a baby's been born and we know that the baby's been born at the hospital? Can we make sure that the OBGYN or the pediatrician knows that the baby's been born and just send them a direct message right into their EHR system? I mean, this is such simple technology that can be used in so many ways to solve so many health problems that require like near real-time alerting. Somebody needs to be alerted immediately. How can we make sure that happens? And direct is, I believe, the way to make it happen. And so it kind of goes back to it's not your grandmother's. Your grandmother's direct messaging. I mean, this is going to be the way that we can solve a lot of problems. A patient has a new medication provided. An alert goes to the primary care doctor to say, there's a new medication for your patient. Is this going to be, a medication that will be able to be used with their other existing medications? I mean, the opportunities are endless to think about. All right, I'll turn it back to you.
Right, and increasingly, payers, caregivers, CBOs, these are all possible places to put a direct address at low cost with complete integration with the existing healthcare ecosystem. So lots of great opportunities, lots of work to do that, there are things to figure out. So one of the things we've actually kind of worked through is actually the directory, which has a huge impact on how effective we can be. So people complain that they can't find direct addresses. We've made a huge improvement in our directory infrastructure over the course of the last 3 years. We basically turned it into a resource that could be used across the ecosystem. It will provide a crosswalk between direct addresses and FHIR endpoints, for example. And direct addresses, as you think about direct addresses, they're frequently, but not always, associated with an individual. And they also do a good job of associating the individual to the organization with which they work. This is something that a FHIR endpoint cannot do. Okay, a FHIR endpoint has no relationship to an individual, but we need to have a way to find that FHIR endpoint, and the directory is a great way to do that, to bootstrap that. So the other thing is that the directory work needed some policy updates. So our policy and our directory was it was not very prescriptive. It allowed people, it was pretty laissez-faire. And so what we did was we tightened that up. We basically made it so all the HISPs after October have to be in our directory. They all have to participate in our directory. And every organization that is served by us has to have an organizational address at least in the directory. So our goal is to try and get everyone in there, at least enough direct addresses so that organizations can be found. So that's big work we're doing. Now, we're also doing a bunch of other things. Now, we mentioned at the top, we do these, we do trust services. Well, we've been talking today to a lot of different organizations about our high trust assessment. This is a piece of work we do. We're a nonprofit, so we're not the kind of organization that actually Kanza uses our high trust assessment. Thanks, Laura, for that. That's helpful. But this is a great thing for us to be able to offer. It's coherent with our mission, but we also have accreditations that are additional possibilities for establishing that same trust. I also want to call your attention to a conference we're going to do in St. Louis, focused on really the tension between the competing priorities the health system is under. There's all of this. It's the same as the triple aim. Like, you've got these two competing things that seem like you couldn't possibly do them at the same time. How can you reduce costs and improve quality simultaneously? That's like, why would I go to, I don't go to, the Quickie Mart to buy my organic groceries. Like, I buy those at Whole Foods. You have to go someplace expensive to get good quality stuff. No, application of technology, we all believe, we're all here because we believe technology can reduce costs and improve quality simultaneously. So I think that there are so many things like that in healthcare now, though. They're being asked to do things that are at odds. So we're trying to help people understand how they can solve these problems. So we want to have a collaborative conference in St. Louis, bring together the healthcare ecosystem to talk about not just interoperability, but actually what it's like to establish trust in a connected world. So interoperability as a fact of the matter, not as a goal necessarily, just what we're already doing. And if you're interoperable, you're at risk, because these are extra doors you're opening to your valuable information. So the other thing, and this is actually quite provocative, and I'm going to invite up Jeff, my friend from Consensus, to talk a little bit about this. So a lot of folks in the room are like, what were they thinking? Is this the DirectTrust conversation, or am I at the right place? We have a new consensus body that's called the Interoperable Secure Cloud Fax Consensus Body. And in a word, this is really just trying to raise the bar on the existing cloud fax ecosystem. What can we do about that? Jeff, go ahead.
Thank you, Scott. Yeah, everybody hear me? So the first point that I'd like to make is, everybody understands that DirectTrust has been involved in a lot of efforts to promote all of their new standards. CloudFax is just another one of these standards. And I think that the key point to make here is whether or not people admit it, everybody in healthcare uses fax technology. The question is, are you using it well? Is it a benefit for you, or is it a challenge? And the idea behind the interoperable secure cloud faxing standard that we're going to be working on is really elevating that cloud fax, that digital cloud fax, into that position where you can be trusting the source, you can be trusting the destination, you can be trusting the communication, right? So it's all about trust, and the fact that DirectTrust is involved in this is for exactly these reasons, right? And I like to think about this in a phrase that I have not vetted with Scott and his organization, but I think that we want to be able to do for CloudFax what Direct Secure Messaging did for email, right, in healthcare specifically, and that is take a technology that is very pervasive and being used and elevate it so that it can be used effectively and efficiently, and be able to provide advancements in the state of the art when it comes to the work that's being done in healthcare. And as I mentioned, everybody's using it, but we want to take the advantage of things like identity assurance, content non-repudiation, a bunch of these things that would be really helpful to know I can trust this fax in a way that I can't trust other faxes. Just like with the direct secure message, I can trust this message in ways that I couldn't trust any old email that I get off the street. And so we're just getting ready to start this. The actual kickoff meeting for the consensus body is next Wednesday, the 6th. There is a link on here. We want a lot of participants, right? There are a number of the leading cloud fax providers that are involved in this group. Obviously, they'll be involved from a technology perspective. There's a lot of technical work that needs to be done here, but there's also the recipients and the transmitters and the interested parties. You want a robust participation in the entire ecosystem when it comes to a consensus body, because there's a lot of work to be done, and you want to make sure that you're solving real-world problems that have real value in being solved, and you want to make sure that all the perspectives are being addressed when you think about these things, so that you can ensure that what you've got here is a solution that is robust, is effective, and really, takes digital cloud faxing to the next level within healthcare and other agencies, other industries where a care about trusting the sources, trusting the content is paramount, which is all of these regulated industries and places where that security is important. And you cannot go a day in any of our regulated industries without hearing about some or other security challenge that has arisen. I know you probably have heard about some of the stuff going on with potential nation-state attacks and prescribing systems and whatnot. It's top of headline. These are the kind of things that these trust frameworks are able to give you that assurance that this system is safe, this system is from well-known sources, and this system is not subject to infiltration or exfiltration, which are real concerns when it comes to our healthcare data in these very, very critical industries.
Thanks, Jeff. Now, we're going to be challenging the CloudFax group, see if they can beat that 3-year record, because that is actually a land speed record for a standards effort. So really, really excited to have been in front of you all today. I definitely want to talk to you about this stuff. If you want to come to our booth afterwards, we got a whole team here. I mean, I don't know about you. I thought ViVE was very well run today. I thought this is a very well-run conference, and I really appreciate the support of the ViVE folks. It's been a terrific event. So really appreciate you all being here, and really excited. So a couple of questions, if there are any. We have like 1 minute left. Oh, we answered all the questions, apparently. What's that? Oh, the booth number. Our booth number is what? 2539. We're booth. You can actually see 2539 from right there. It's really close by. So come by and say hi. There are 6 of us. So even though if there are 12 of you, it'll only take a minute to get through the first in the line. So thanks so much for coming.
Thank you.
Thanks, everyone.